drinking?
Crack.
Ah, sounds good.
Right. Sounds good.
Monster Zero. You can't get enough.
All right, can you guys hear me? Yes, no?
Yeah.
All right, I think I can talk loud enough. I'm pretty good at this. Okay. Well, good morning, everyone. I see a lot of familiar faces. Very astute colleagues, all from workers' comp, from the legal side, from the adjuster side, insurance, everything. So it's a pleasure to be here. I see another one of my colleagues right in front of me. So it's a pleasure. I don't know how to make this book any more interesting than it has already been to us. I know my responsibilities here is to make it interesting and understandable, but I'll do my best. So good morning. Let's talk about what the book is. This is the 5th edition. There's many different editions at this point. We're on the 6th, although not here used in the state of Nevada. What's good about the 5th edition over the 4th that we used to have is the 5th came out around 2000, and it's a product of a very nice format of which was established in the 4th edition. Each chapter has outlines in the front of the chapter. The outlines are somewhat thumbnail sketches, so if you're unfamiliar, just go to the first pages of each chapter, and it gives you a walkthrough of how to use the chapter. It's very simple. It's actually quite nice. They're bold-faced words, which means anything in bold-faced in the initial parts of the chapter are in the glossary for definitions to make life easier. I see a lot of people initially have a lot of questions, and if you don't know the book and knowing what the highlights and the asterisks and such, and you gloss over that, you lose a lot of the meat and the knowledge. So every chapter in the 5th edition will give you what you need to do in a rating. It gives us parameters, how to establish the percentages, and how to utilize the book. At a minimum, you should be familiar with the bibliography to see how actually the 5th edition got established, period. The first and second chapters of the 5th edition AMA guides define the outline, which is the methodology of how to do a PPD. So the first 2 chapters are superior to every other chapter in the book. It is the constitution of the guides. So the first and second chapters supersede any other chapter in the book. So the first and second, or particularly the second chapter, allows a rating physician to rate by analogy. Means that if you have an area where there are no true measurements, you are allowed to evaluate, do the history, and come up with a percentage by using ideas of what the intent of the book, how it was written, such as a chapter of psychology, which Dr. Saishan will be talking about. There's no true numbers in this chapter. There's no number to rate a patient. It is an agreed upon way of establishing a percentage when you're doing a psych, say, such as PTSD rating. So you have to, there's no rateable measurement of objective tests, so you have to rate by analogy, and that is established and permitted by the first and second chapters, period. AMA guides are used various ways throughout the world. It's not just Nevada that uses this book. Various books are used throughout the United States. Every state has its own work comp rules, and it's also used throughout the world. That's used in personal injury claims throughout the world as well. It's not so much used, I mean, well, it can be used here in Nevada. It depends on the attorney involved and how to establish a value for a case, and that's what we're here for. It's a way to combine medicine and law, and it somehow gets squeezed together to come up with a value of what an injury's worth. You know, is it catastrophic injuries? Is it a small injury? It's a way we could get to actual damages. And actual damages, it seems easy. It's a loss of property, doctor's bills, actual costs. But when it comes to non-economic damages, it's loss of consortium, loss of activity, pain and suffering. These are the items that we utilize the book to get there. Such as the $5 million settlement from McDonald's of spilling hot coffee in your lap. So there's an economic damage, and they have to come up with a value. And this is our way of coming up with the values, utilizing the AMA guides. So this is about all legal action is about money. This is about money. This is about taking care of injured workers and giving them their, I guess, a reward for an injury and coming up with a standardization. So, well, it is. You can't. You're paying. It is an individual who's injured has to give. It's a reward. It's a quantum number. So, and this goes back to the rules of Hammurabi and everything, an eye for an eye, things like that. So this is nothing new. This is, you cut off a finger, well, then there's a value for this. So this has been around for thousands of years, coming up with.
Painful word.
Yeah, well, I mean, is there a better word for it?
Compensation.
Yeah, it's compensation.
State
Yeah.
award compensation is always what I say.
At the end of the day,
Because the employer's like, oh, it's a state award.
yeah,
And
yeah.
therefore, it's not so questionable on the other side.
Well, I think we have a pretty good system.
Yeah, which blows my mind because, I mean, it's the law, it's the system, and every group has given up something in order to get into the industrial insurance system, whether, and trust me, there's what you like and you don't like, but it's the law, so I don't know why you need to justify anything.
Well, and I don't know that it's justifying. One of the, actually I gotta move over a little bit. I think one of the things that happens is, as adjusters or administrators, when we're setting the reserves for that award, it's hard for employers to understand when you have $8,000, $9,000, $10,000 worth of medical and a $200,000 award.
Exactly.
And so you have to use the right words so that they can swallow it. That's the only reason. We're not justifying it. I think it's very appropriate. I think people absolutely should be compensated for the tragedies that they certainly lost wages. It's a word game to make it more palatable.
Right. Well, the AMA Guides is a cookbook. It's a thinking person's cookbook. It's an art of medicine. So therefore, as a doctor, whether it be MD, DO, Chiro, we need not to divorce ourselves from being a doctor while doing an exam. So you can't remove the examiner from the exam, and you need someone who just has integrity and has knowledge of the book, and to utilize the book with the way it's intent and how it's written, and to have someone with the integrity to come up with the accurate percentage of impairment. So I've seen, and I'm sure at this point the whole room has seen, impairments and rating PPDs that some are exquisitely high and some are exquisitely low, and somewhere in the middle is the actual number. And how do we get to that is by, well, knowledge, understanding the book, collaborating with colleagues, and understanding, this is a thinking person's book, and it's not a perfect book. It's a nice book, but there's different versions. And there's the 6th edition and the 5th are quite different. The 5th is based off of range of motion method. It's very heavily based off of that. And the 6th is based off diagnosis method and activities of daily living. So there's a juxtaposition between the two, but they're both very good books. So, and sometimes with regards to range of motion, which we'll see with fingers and lumbar spines and every other body part, Sometimes it's in the eye of the beholder. This is why we get a wide variety of results. There's poor reproducibility with some of the range of motion and some of the testing. And you are always looking for a rater who follows the book with integrity and predictability. You want a test to be as accurate as possible and have other raters be able to do the same thing and come up with relatively same percentages. So,
Can I ask a question at that point?
sure.
One of the challenges that I have found when I'm reviewing PPDs with range of motions and stuff like that is the prior medical records are substantially better with range of motion, et cetera. And then when they get into their PPD, they don't have that same thing. And my question is, what weight does the medical records, PT notes, et cetera, carry when you're looking at a claim and you're saying, okay, here's what I expect, because this is what the medical reports show, this is what I see.
Right. It's a difficult question to answer.
I live it, I understand.
Right. I say, I'll go back to integrity. You want a rating physician to give a good exam, but you're only as good as the effort of an individual. And that is where there is a bridge between results from PPDs. And that is a, I can't explain, which we all know, about human intent, okay? I know what my pain is. There's a, Kevin, maybe you could help me. It was a Supreme Court judge who said, and he utilized it with pornography, but in this case, I'm going to say with regards to pain.
So I'm able to help.
No. He says, I don't know what pain is, but I know when I feel it, what it is. So there was a Supreme Court judge who stated that I don't know what everyone else's pain is, but I know when I feel pain, I know what it is. But it's difficult to explain everyone's pain. So, and how the Supreme Court judge, I forget his name, it was a case on pornography, and he goes, I can't explain what pornography is, but I know what it is when I see it. So this interpretation which was used with regards to pain in the pain chapter, which has been statutorily removed in this state. I don't know what people's pain is, but I know when I hurt what it feels like. So everyone's ability to go through their own pain levels is quite a personal event. So to answer your question, what I see in the records when it comes to pain, range of motion, I have to go back to, did they use the book and how the evaluation with regards to range of motion, were those range of motions measured based off the book? So typically, no, they're not using the book. I have, and I'm sure some of my colleagues here has asked, well, has the treating physician measured? Because you'll see the treating physician's records in there say, oh, they have full range of motion. Okay. No, they have said full range of motion.
Right. No, I agree with you.
Okay, and then
They're not
they
using
say,
a micrometer.
well, no, they didn't even touch me.
Right.
Okay, well then,
How do you
not to
define full range?
remove the professionalism of the treating physician. That's not our job up here to do. But when a treating physician, which we've all been the doctors ourselves, we've all had a surgery or two perhaps, or broken a bone, when they go, can you move it? Yeah, well, you can move something, and as long as there's function, and I don't have orthopedic surgeon, they don't have the time of the day. They're doing surgeries, they're busy, they have families, they have children. Their son just crashed the car, the check bounced, you name it, everyone has a life. I don't see a lot of true range of motion
And
testing.
I don't necessarily look at the physicians. I had an old time, a long million years ago when I first started, doctor tell me, I wasn't trained in work comp, I don't know return to work, that isn't what I do.
Right.
But what I am interested in is the physical therapist notes. Because I feel the physical therapist notes are doing the range of motion, are doing the tests, and are looking at it. And it's sometimes frustrating when there's a significant difference and there's no comment. I see that the physical therapy says this, however, that's not how it is for me. And like you said, my interpretation as a professional for the PPD, this is what I see.
Right, so.
Hold on one second.
We have one
Mr.
from
Kevin
Dr.
wanted a
Morgan as
question.
well.
Oh, no, so thank you, Dr. Resin, for that answer, because oftentimes when you're posed with that type of question, where you try to give, you gave a medical answer and something based on medicine, and the fifth edition, the difference between the treating physician and the rating physician, so I appreciate that. I just want to walk this forward a little bit, because what we see is, although you hadn't necessarily raised it, is that if the insurer administrator, whoever it is, sees something like that and they see range of motion findings at the PPD that are, in their view, drastically different or even different than whether the treating physician left off, that becomes a dispute of the rating, okay? And so making sure what we're finding is that certainly if you dispute the PPD, there are legal mechanisms in order to obtain a new PPD, and that's the remedy. What there is no legal basis for is for an insurance company or whoever, the employer or whoever, to make a unilateral finding that based upon what you're saying and based upon what the treating physician said, that they're not MMI. And so we're gonna go ahead and we're gonna send them back to a treating physician, we're gonna send them back to a doctor, and we're gonna send them back for more care when there really is no legal basis to do it. And you only have 75 days in order to dispute a PPD. But what I'm seeing more and more, of course I haven't seen it because I've been out of the game for a couple of months, but I'm back now. But what I'm seeing more and more is that instead of just disputing the PPD, okay, which you have a valid legal reason to do, you're really disputing the MMI status, which you don't have a legal standing to do. And then you're going and sending people back to doctors and things like that because of things that are disputed. And so I'm just seeing that more and more, and certainly it goes outside of the 75 days, and there just isn't any sort of legal avenue in order to do that. If you dispute the PPD, whether they're findings or something else, there are specific laws in order to dispute that PPD, and I'm seeing that abused significantly.
I have to agree. I mean, I think because what we see with the amount of money now that which shouldn't be relevant, I understand that, but in my world, because I have to do reserves, it is, that you're right, it is. So those of you who are administrating, make sure that you have sound judgment and you have legal advice and you're going down the correct path if you disagree with that PPD that you found. Doctor.
Thank you. And to add to Dr. Razadin, it is a real challenge. There's so many factors involved. Where it's been 6 months since they've been discharged from PT. At that time, they're getting care 3 times a week, active care, and now they're back to cleaning rooms, 16 rooms a day.
Oh.
And we all know we've probably had good days and bad days in our life and our health, and trying to correlate that with, well, their discharge from January 19th showed they had 150 degrees of flexion in the shoulder. Now here it is July. I find when I do comparing my notes and PT notes, my exam findings, frequently I'll find one motion I find is greater than what PT found, and one is less. It's not always just skewed as in they're giving poor effort or they've fallen apart. And I find in the real world, if I try to deem them not MMI, unless they've got a significant injury or crash or fall, if they go back to the primary care, which is using or the surgeon typically, I'll see them back in a month or 2 or 3, nothing 6 years in this process.
God bless him.
Only 6 years. And he's flying from Albuquerque to see me with a back injury, back implant stimulator. You think you might have some pain from traveling? We all do, right?
Yeah.
But it's just emotional from traveling now, and physical. So, but all these factors involved, when the treating physician says they have functional range of motion, I'm really not sure what that means. Full range of motion, what's that mean? And like Andre will ask, say, did they measure you? I show them the goniometer. You're like, I've never seen one.
Right.
So I like to put that in my report, explain the scenario, saying, I asked the patient if they were measured the same way. They admitted they were not. And most PTs or even surgeons, they'll measure 3 of 6 range of motion of the shoulder. So apples and apples just don't really exist here. I understand your issue you're having because what you put in reserves is being challenged. So it's just I'm trying to make these cases, wrap them up, do them fairly, do them accurately, do them defensively, and not send them back up there for surgery, and not question MMI, because now they're no longer medicated. Their medication supply has been cut off because they have no more benefits for that. And it took them 1 to 3 or 4 months to see me, and so they're back out working hard. I get it, good days and bad days, and I always try to encourage them. Expect tightness and discomfort, but don't move fast. You shouldn't hurt yourself. And if we do it over and over and over, usually we get a fairly consistent effort. We can encourage them, but just I understand your point too. Like, hey, how come these numbers are different? That's just how it is. But some are greater, some are lesser, and so it's a challenge, and we see it every day. The anxiety they have, they're sweating, they're nervous, they're in pain, they're suffering. There's a whole variety of psychosocial factors involved, and then maybe they've been coached by their team or friends or coworkers. They understand the system. Less motion, more money. It's not a complicated riddle here. So the reality is that often they're injured, and the reality of people in our lives people are getting sicker and worse and more inflamed, more diabetes, more health problems, comorbidities, and that day they won't take ibuprofen. So guess who doesn't feel as well? And most of us in our life have taken ibuprofen Tylenol because we don't feel well. Are we fooling ourselves or faking ourselves? No, we're trying to be more comfortable, and they realize they want to show the real picture of themselves. So in reality, they're showing their genuine colors. They're not medicated.
Right.
And
Now,
we're asking for genuine efforts. And
also
That's
see,
Dr. Hogan, by the way, Ken Hogan.
yeah.
I was just gonna say that was Dr. Hogan.
Right. You also see that some doctors have a ruler, 12-inch ruler that's 18 inches long, and another doctor has a ruler that's 5 inches long, and how they're rating, because what we're using to evaluate patients are a plastic measuring device, a goniometer, inclinometer, things like that.
It looks like something you got in geometry class.
Correct. So, I mean, the accuracy, some people spend a lot of money to get these digital ones, and they attach things all over people's necks and do muscle EMGs and all these things, and say, well, it's backed by NASA and all sorts of things. And it really still comes down to answer the physical therapy notes. Yeah, of course, I've seen them. Ken's seen them. We have all seen physical therapy notes. And I have to go back, that I wasn't there. Both sides, adjusters, attorneys have said, hey, what do you think about this PPD, this report? And I go, well, the methodology of how that's really how I can evaluate, and Ken here, same thing, to evaluate, did the rating physician utilize the book appropriately and according to how it's written, which means, was the method of evaluation done correctly? Now, when it comes to range of motion, I don't know how it was done. I wasn't physically there. And that being said too, if the rating physician measured at the same time, it says things like atrophy, measuring the leg, things like that. And it says, well, within 10 centimeters and up for the patella and this. And I think that I don't want to get into the minutia of this. As long as the rating physician measures equally both sides, consistently, that's what you want. If it's done correctly and fairly. There's room for error or mischief. Call it whatever you want. The measuring tape is a measuring tape, but it's how you move this measuring tape is where you're going to get inaccuracies or accuracies. So, I mean, just listening to Doc here, He's absolutely right. You know, the physical therapists are very professional. I've seen the work. I know a lot of physical therapists that we've all been here for a long time that are wonderful in what they do. But when it comes down to it, I'm not there to say, was it done the way the book asked us to do it? And is there some consistencies? Chapter 2, I go back. It's a first chapter says you're allowed to disagree with another physician if they're inconsistent with the guides. So as long as you have consistency in the way the evaluation was done, you'll get at least reasonable conclusions and impairment percentages that could be reproducible by another rating physician. How does that sound?
Excellent. I also want to make a comment from Dr. Hogan when he said, if you're flying somebody in for a PPD, don't be chintzy on the flights. Bring them in the night before, let them sleep, buy them dinner,
Put them on
couple drinks.
Southwest.
Let them go.
Or Spirit.
And let them come and let them show up tomorrow morning for the PPD, because if you take them off the flight to the PPD, you're gonna pay.
Yeah, and you get, listen, human nature is human nature. How many patients have come in? I've had patients all over the map. I mean, I just don't get, you know, a bear or a monkey. I get the whole zoo that comes in. I've had a patient come in stone drunk. And
Nice, that's a good range of motion.
No, well, actually, he was drunk.
Yeah.
And I had all emotions, from crying to wanting to fight to angry about the employer, having, everyone's out to get him, the adjuster, I mean, all over the map. So we're
He was probably loose that one, but.
well, yeah, it's great range of motion, right? So we're still dealing with people's emotions. You don't know what the aggravation was. You don't know, and then some of it comes down to money. You know, they can't afford to pay their bills. And I don't know all the intricacies of how everything needs to be paid and TTD and this and that. I just don't get involved in that. But I do hear it. That's an aspect. And when it goes for a long period of time, I hear, though, I lost my house, I lost this, I had a police officer.
That's no joke. That's exactly.
Right.
I've had them pull up in their car full of stuff because they lost everything because
Right.
of the claim.
I mean, I had a police officer. It's unfortunate. Metro jumped over a wall. Unfortunately, the wall on the other side wasn't the same height. It dropped an extra 10 feet. So he didn't know it. He was going to help his partner in a shooting here in town and had compression fractures of low back.
Oh.
He had 4 failed back surgeries. And finally the surgeons said, well, you're just drug seeking and there's nothing we can do, and get out. Well, he finally came to me, and I was treating, but it turned out that the pedicle screws that were screwed in had broke. These titanium metals broke. So the pain he kept having was because the surgery failed.
Right.
And who prescribed all the opiates? It wasn't
Yeah.
you guys.
That's another plan.
Someone had to prescribe it.
Yeah.
And now this poor officer lost his wife, lost his 4 kids, lost his teeth from the medication, and has a failed back surgery that's not fusing. Well, you're going to get some people that are angry,
Oh, very.
and we're all human. So we have to still look at the humanity that's involved in what we do. At the end of the day, I mean, we can't, I know, we have to save money. We all bow to a certain, you have a question?
No, we kind of need to move.
Oh,
on
yeah,
to
okay, I'm
your
verbose.
homework.
Sorry, we
Yeah,
haven't.
but we can talk for 4 hours about every topic. We have less than an hour to talk about
All right,
health.
all right.
Then we're gonna talk about psych. If he loves this, we will treat you.
So, okay, so we still can't remove lumbar and hand. That should be a 5-minute
Do you
method.
want to use this, or?
Sure, I'll use it. So, all right.
They're putting you in a box, Doc.
We can't, yeah.
Put you in a box.
We can't remove the humanity from us still being human for the people that we're trying to work with, help, assist, and get them on their way.
I think they should see a picture of your AMA guides. That's amazing. That is wore out. I have a couple adjusters I've seen that are bad, but that one is outstanding.
Well, this has
Might
been
need a new
rebound
one.
4 times.
And what he does when he does the training at your office,
Yeah.
that can take up to 4 hours, he will give you pearls of
Well,
wisdom that are next to each
but the
section
reality-
that have been good and bad ways of what the book says and what
Yep.
you're gonna find and what you're gonna need.
To really go over this book,
So,
we can't do it in 2 hours. This is a,
how many times have
16
they buying?
oh, 4 times. But this is a book that really, you gotta get into the weeds on this one and really understand the intent. This is a easy 16-hour lecture that we can do. But, I know I can do it. I don't get quiet here. So, okay, well, I guess my job here today, I feel like the 8th husband of Zsa Zsa Gabor. I know what my responsibility is, but I don't know how to make it any more interesting. So let's go to chapter 15. I don't know if anyone has their books. That's okay. We'll just talk about DRE category and range of motion method. I don't know how the book's been around from 2000 and we still have some confusion on this. There's 2 methods, and I'll try to make it as simple and as quickly as we can since I am on the time clock. DRE method. That is a, got it. Oh, I can look at that. That's fine. DRE.
We just want
It's
them
a
to be able
fancy
to see
way
what you're talking about.
of saying diagnosis method. Okay, it's based off of a diagnosis of a sprain strain, a surgery, and a discectomy, and a fusion, and or fractures, or movement of a joint. Okay, that's the diagnosis. Range of motion, self-explanatory. The spine, we measure based off of range of motion. There are rules. So to make it simple, there's a, let's see, where are we at? You can't even see it. But the DRE method, that small little table establishes, and there's, the same table's designed for the neck, mid-back, which is cervical, thoracic, lumbar spine. DRE category 1, it's essentially no significant clinical findings. It's complaints only. That's what it is, okay? Throughout the United States, historically, judges have a hard time giving zeros. The 5th edition fails us here, okay? I think the 6th edition does better because it gives a little bit in this category of category 1. Judges don't like, hello.
Hey. I'm just going to hopefully make that more legible for you guys.
This is Dr. Tawil. He works with me. We've been friends for just 35 years. He's a chiropractor, went to Dubai, became a pain management physician, and well, he's back here. I mean, we're working together. So, category 1, the judges don't like giving zeros. We all have emotions. So simply, if someone gets hurt, they tell attorneys, please go both sides, go figure it out. Maybe they deserve something. So category 1, it just has 0. There's nothing to offer here. It's a diagnosis, and that's it. And they have pain. It's a complaint only, and you get nothing for a complaint. We all have complaints. We all hurt. Okay. Some days worse, some days more. Workers' comp for me, and like if you go to Haiti, there is no workers' comp. If you have an amputation of your leg, they give you a broom, here's your stick, good luck. Here in the United States, we have a wonderful system that if someone has an amputation, you get bionic, electronic, durable, prosthetic. But it's because we have means in this country. There's money. So depends where you are when you get injured. Thank God we're lucky enough to be here in the United States, absolutely. The second, category 2, it's an interesting category that was created for essentially sprain strains. okay? It's a percentage of 5 to 8%. But if you can't see it, but category 1 gives you a 0, and we jump directly to 5. Well, what has been missed in between? We have a 0 to a 5, and we have not 1% to give someone, not a 2, not a 3, not a 4. We go jump straight to a 5. Well, the 6th edition has taken that out and said, you know what? Pain is something. There are activities of daily living relative to this. We're going to give everyone a 2%. If there's nothing, you get a 2 in the sixth edition. Problem is, the values have changed so much that going from the 5th to 6th, you actually get less. So there's our quandary. So the category 2 is a spasm and guarding table or category, and it's a medical legal compromise here. This is the lower end. In order to get up to the next category 3, 4, 5, it gets tighter as it gets up. Category 2 is a soft and nebulous, very liberal category. If they can describe it, well, typically they get it. Oh, it's okay. Yeah, do your thing. So it's a presentation with sometimes no objective findings. And when I say no objective, there is objective findings, but it's how it's interpreted, and it's based off of the page right before, some definitions of clinical findings, such as muscle guarding, asymmetric loss of range of motion, non-verifiable radicular root pain, these reflexes, okay, atrophy, now that's more objective, but radiculopathy, these terms are used very kind of loosey-goosey with treating physicians. Someone who says radiculopathy, is it radiculopathy? I don't know. By definition, is it based off the 5th edition AMA guides? These are the rules. That's where perhaps treating physicians squint a little bit to see the muscle spasm. Okay, we all have pain. Yes, ouch, ouch, ouch. Got it. Is that a spasm? Is that subjective? Is it objective? That's where category 5 kind of was created, period. Is there some abuse? Yeah, perhaps. That's why they came out with the 6th edition which automatically gives a 2%. So, but the fact that you take a category 1, you give it a 0, and then we don't even talk about it until you get to a 5, well, that's a big hit for the insurance companies too. So sometimes we're only limited by what the tools we have, and the tool we have is this book currently. So then there's a 5 to 8. What establishes an 8 as opposed to a 5? Okay, that's somewhat a subjective category where on page 4 you go to chapter 1 and we look at the activities of daily living. Then the confusion is well, in the state of Nevada, we don't use activities of daily living. It doesn't apply because there's no pain in the state. You can't use chapter 18. So when you say, oh, it hurts when I do this and this and this, it's, oh, sorry, can't give you anything for that because that's a pain. Well, I can't brush my teeth, comb my hair because of this. Well, now that pain is related to an activity of daily living, so there's a variable between 5 to 8%. So there's 3. We're looking at 3%. Well, 3% is money at the same point. So how does a rating physician give an addition ADLs, activities of daily living? There is nothing in this book that will explain to a rating physician how to do that, how to opine on that, how to come to that conclusion. It's not taught. Doc, have you been taught that at the where we go? It doesn't exist. So where a rating physician has to, oh, by the way, he said no. So you have to rely on the patient themselves, or the claimant themselves, because they're not our patients, the claimant. Like I said, you can't remove the doctor from the exam, and you have to have someone who's knowledgeable of the book and still asks enough questions to have some sort of personal, not relationship, but engagement with the claimant to see, is this person, are they telling the truth? Can they explain? And we all know. You know when you see someone who's actually in pain, or there's some a little bit exaggeration and such. I have heard during some courses that an instructor had said in the past, and he's an attorney and an MD combined, not in this state, but he's an instructor, and he said, I like when a patient exaggerates a little because it makes them human. But if they exaggerate a lot, they get nothing because that's just a gross exaggeration. And to that, how I'll explain is range of motion. When you ask a patient on their good side to give full range of motion, well, they do, but they also stop themselves. We all do. We just go, oh, okay. And they stop. I'm using my shoulder as an example. But they don't know what and why we're asking it for range of motion with regards to the lumbar spine or anything when you're flexion, extension. They just stop. Well, if a rating physician, and that's where integrity comes in, and that's where you see a vast different rating, I ask the patient, can you move more? Well, yeah, I can move it more. Well, why don't you? I don't know, I stopped here. Because they don't know what we're trying to get at. They don't know we're supposed to, on page 453, compare and contrast contralateral joint. So perhaps the injured worker hurts themselves in an exam. So you want a rating physician who says, no, sir or ma'am, please, you have to go all the way. So you do a full range of motion. And that applies to the injured side. But we also held to a standard that we can't injure the worker, and our own abilities to say, well, okay, you got to stop when it hurts, which is in the book. It says you have to let the person stretch and this and that, and you can't make it worse. So there's a certain context. So category 2, getting back to this, is a legal compromise, basically. You have to understand a rating physician is to rate, but we're not investigators or detectives. That's not our job. As much as I don't like certain things, if they don't give full effort and they say they're in pain, I have to apply it and I have to move on. Because as a rating physician, we're not adjudicators, and most certainly I don't have a lie meter. That was never taught in school. So you have to ask, and we do see, a regular PPD might take at least an hour to an hour and a half for me, and I have to ask a series of questions to see, are they consistent? Are they answering questions with some honesty? Did you drive here? Are you able to interpret a red light from a green light? Does someone feed you? Do they care for you at home? What is your impairment? And then that's how ADLs are applied. Category 3 on this is, now here's the jump again. It goes from an 8 to a 10. What happened to a 9? It just doesn't exist. It doesn't even let the rating physician offer it. So we go to a 10, and then it could jump to a 13. Category 3, it's related to radiculopathies. Objectively, EMGs, nerve conduction studies, are important. They're discussed on page 378, 382. And then a history of herniated discs, a discectomy surgery, and or fractures. They're included in category 4. Well, we jump from a 13 to a 20. There's nothing in between. Say, you know, it's probably a 17. No, go straight to a 20. That is, this one is a fusion. In 2000, there was but discussion and lack of knowledge. Rating physicians don't know how to rate a disc replacement. Okay, well, disc replacements are not in this book. They don't exist. And why doesn't it exist? Well, in 2000, or actually this was printed in 2000. Prior to 2000, disc replacements were not the norm. It was experimental at best and not utilized on a regular basis. So today, disc replacement will fall in the category of category 4 for 20%. It'll be equal to a fusion because at the time of its writing, it didn't exist. So, but the good thing about the book in the first and second chapters is you can rate by analogy. And in this particular case and instance, this is where the first two chapters supersede every other chapter that a rating physician could rate by analogy and compare a disc replacement to a fusion. Now, category 5, at the end, we jump from a 23% maximum to a 25 to 28. Category 5 is a terrible category. It's high numbers, I get that, but the only reason they get there is because this is a failed fusion. Okay, this is someone who has a fusion and has radiculopathies and a lot of problems. So they get a value, or it's a fracture of greater than 60% of the bone itself. So there is variabilities within these categories, and it's partly because of ADLs. Now, do people deserve them? Yes, but to what percentage? I don't know. Yes, next one.
Can you explain how you go from a 1 to a 3
Sure,
on
sure.
ADLs?
Sure. So I was asked, how do I interpret ADLs? It's on page 4, chapter 1, 5th edition AMA guides. Quickly, there's 8 activities of daily living. Self-care, personal hygiene, such as can you urinate, defecate, brush your teeth, comb your hair, bathing, dressing oneself, eating. Next is communication. Can you walk, write, type? Can you see, can you hear, can you speak? Physical activity, standing, sitting, reclining, walking, climbing upstairs. Sensory, can you hear, can you tactile, can you touch, can you feel, can you taste, can you smell? Non-specialized hand activities, such as grasping, two-point discrimination, traveling. Can you ride in a plane, train, automobile? Does it hurt? Sexual function. Here's where I see some differences, call it mischief, call it whatever. It's about the orgasm, the ejaculation, lubrication, erection of the injured worker. It is not, my back hurts when I'm in a position.
We got deep real quick, hold on.
Well, it's in the book. This is nothing, this is just a professional interpretation. So it's not, well, my back hurts. Well, I'm sorry your back hurts. That's not what activities of daily living. It is established in the physical activity, such as bending, stooping, things like that. Sleep. It's about restful sleep, nocturnal sleep pattern. It's about daytime awareness due to lack of sleep. It's not, well, I didn't sleep too well last night. Okay. Well, this should be supported, I think, objectively with sleep studies, but no one wants to pay for a sleep study to even establish that is their activities of daily living really objectively, quantified. So, we have to understand that there's a big bridge between impairment and work, or someone's ability to work, and that's where ADLs come in. And this is, ADLs are really heavily rated with regards to the federal government and disability. This is not a disability exam. This is an impairment exam. This is about the function of the joint and the function of that body part as it relates to the work injury. So how I go, and it's difficult, and everyone has their own way of interpreting how ADLs should be, given. I've yet to see one person that falls into every category of these 8. I mean, that'd be a very injured person to fall into all 8 categories. So how does one get a 3% as opposed to a 1% ADL? I can't answer that for anyone else but myself. And I say, if the person falls into at least 2 categories, which is very, very easy. If someone has a neck problem and they had surgery, a fusion, and have some radiculopathy and tingling, I say, okay, well, there's one, because they have difficulty combing their hair. I don't have a problem. I could use any soap. I have no hair. But our professional women in the audience have much longer hair than I do, and you have to work with it. I know, my girlfriend has very long hair. It's a mess. I've never seen so many shampoo bottles in the shower. I don't need it. But if you're injured, it's difficult to do that. So I've had patients go, I just cut my hair because I can't do it anymore. I can't raise my arms. I just put it in a ponytail and go. All right, perhaps some of you can relate. go shorter. It's easy. So there's 1%. Can they communicate? I don't know how a low back is going to affect your communication skills. There's nothing there. Physical activity, sitting, standing, reclining, yeah. Traveling. I got on a plane, I can't, got to stretch, I got to get up. I got, how many times, sir, you need to sit down. I go, if I keep sitting down, I'm opening up the emergency exit. Patients have this pain. So, okay, they may get 2 points for that, but to get an additional 3, they have to really show me some objective findings that their activities of daily living are really affected. Doc?
I like that. And it's also practicality where if it's a low back patient, they shouldn't have a 2-point discrimination issue or a hearing issue. So that adds to the validity of the patient. So I'm more generous if I feel they're valid and give me a fair pitch.
Oh, you got me.
You see, I agree with Dr. Razadin. If they have no complaints of ADLs in the form, then they get 0. If they have only a few, which seem reasonable, they get like 1, maybe 2, and rarely they get 3%. And again, I try to, in the big picture, is this person given a valid presentation? Lower back DRE 2 shouldn't have vision problems related to this. And always ask, is this related to your back? Like, yeah, I can't see so because of my back. Like, that's a stretch.
Right.
So I'm probably less generous in that case because I feel like it's less valid, their presentation. Also, when it comes to ADLs, my practice is if they have a cervicothoracic lumbar rating, I'm not going to give ADLs for each one. Essentially, if they can't sit for so long, they can't tie their shoes, they can't exercise, irregardless is thoracic or lumbar, I'm not going to let them double dip on it per se. I feel like it's one activity. It should be given each
level.
region of the spine.
Right. But that's not how it's written, though. So you're going to have different interpretation of the same
And
book.
I think it's easier for me to do that than saying, okay, I'll give 6% for cervical and a 6% for lumbar and 7 for thoracic. To me, that looks a little more even bizarre and impractical. Because your neck affects your hair, but your low back affects your sitting, and like I don't want to go that rabbit hole. And
agree.
just like there's one group of ADLs, follow that, and most doctors don't use that. Look, page 4 as he references perfectly. A lot of adjusters understand how do you come up with these ideas. Just look at the book, page 4. Those are the ones we have to reference. So it's not perfect. We got to deal with it every day too. I wish it was easier, but it is what it is.
Right. So moving as fast as we can. So we have, I don't know, stand, walk, and explain. These 5 categories are based off diagnosis, based off a fracture, a surgery, and objective findings. Period. Everything is included. I give you permission to use this. Everything's included in the DRE category. It's like going to the buffet here in Vegas. Once you get in, everything's included. Radiculopathy, the surgery, if a fracture, it's all in a category when it's your first injury. You get it all in one in a category when you injure yourself your first time. If you go to second injury, this does not apply anymore. Now everything's a la carte. You're going to Capitol Grill, everybody. Everything is by itself. Meaning you have 3 bites of the apple. What does that mean? You get a diagnosis category, you get range of motion, and you get a nerve. There's 3 items. So, first injury, you're in the category, whatever you fall in this category, that's what you get. Second injury to the same body part, whether it's a neck or low back, you now move into the range of motion method. What is a range of motion? It's either a second injury to the same body part or multiple levels in that body part. Well, what does multiple levels mean? 2-level fusion. There's your multiple levels. 2 fractures. There's your multiple levels. It's not specifically, they have 3 disc bulges. Well, I tell you, we all have 3 disc bulges. They exist. Not everyone has signs and symptoms because they have a disc bulge. So you cannot arbitrarily just go, 3 disc bulges, you got 3 levels, it's a range of motion. No, there has to be some objective findings such as EMG, nerve conduction testing, and I have to admit we have a wonderful doctor in town who's sitting right in the back who's excellent at EMGs and nerve conduction. So I think he's an expert of it, and the knowledge he has is wonderful. That's Dr. Mashoud in the back. So he's very knowledgeable, and when I have questions, I call him. He's excellent, excellent person to use as a resource.
Whenever I saw radiculopathy on the medical report, I said, prove it, send it to Dr. Machine.
Yeah, no.
Because if I'm gonna pay for it, I wanna prove it.
Yeah, no, he's, Doc, I'm singing your praises. You're good at what you do. Okay.
Can you push the PowerPoint up? There is a case study. Some of the adjusters want to know more about the actual, how you apply the DRE versus range of motion, so then we can move on to the hand.
Yeah, there's a table.
There is a case study down further.
Case study or a table?
No, in your, on the
Yeah, flow chart.
there's a case study that talks about how you apply the
Well, I know.
DRE versus the range of motion. There's an actual case in there.
Oh, I see.
I think it's down a little bit further. I mean, you're gonna talk about how you apply them most.
The rules, got it. Well, here's your 1310, what causes,
It's down a little
creates
bit
it.
further
Yeah, I
than
needed
that.
you
It
up here.
just walks through a case where how you apply it. Just because we're short on time,
Yep,
this is
yep,
actually a 3-hour presentation, so. There's an example.
Sure there is.
There is.
Somewhere.
She's like, I've seen this presentation how many times?
Dr.
So,
Russell,
yes.
I have a question.
Yep.
So, I know this doesn't seem like it comes into play, but someone that has, their body count is prior to being work comp injured, I'm just wondering, you can't really take that into consideration that, they can only raise their arm this hard. Well, I can only raise my arm this high now, so if I injure it, I can't go this high. I mean,
I know what you're saying.
you know what I'm saying?
You want me to answer that? That's a tough question, but it's okay. Correct. If someone has a certain body habitus, I can't say, well, we can't review whichever. The book, the only thing we can do is go to page 453, it's the bottom right corner, it's right in the middle, the paragraph says, you may, it doesn't say you must, you may compare and contrast contralateral joint and compare and use that as a baseline, of which the tables do the same thing, such as in the hand and such, but you've got to compare and contrast contralateral joint. You can't compare a contralateral joint when it comes to the neck, mid-back, low back, because there is nothing to compare it to. If someone has a pendulous belly, a man that comes in and the belly's out to here, and that's as far as he can move, that's any rating, that's all we can do, okay? Can we say, yeah, based off of their body type, it makes it difficult? Yeah, but that doesn't, nothing, I can't change the fact that that's how we're supposed to rate them as we see them. And that's it. So, is it fair? Is it, no? But when it comes to upper limbs and lower limbs, at least there's a mechanism that we can compare and contrast contralateral joint and use as a baseline. That being said, you still have to ask and say, did you ever injure that body part? Or have a fracture, anything in the past, in the history? And if they say, yeah, I broke it when I was a kid, or things like that, well, at some point you can't utilize that opposite joint. So I'd say as a rating physician, you do your best with what you got. With regards to the equipment you have and the effort of the injured worker, as well as how, were they injured prior? So the book allots for it, page 453, compare and contrast contralateral joints. So no easy answer other than we do our best, we try to compare, you're supposed to compare, doesn't say you must, it says you may, and you utilize that as a baseline. When I started here 16, 17 years ago, not everyone was comparing. Everything has gone through cycles, so there wasn't always comparison. It became much more prevalent as the years have gone by. Just like we could get into distal clavicle receptions. Before there was no argument, now there's an argument. I think it's been removed out of the 6th edition, or incorporated in the 6th edition. But, like I said, we didn't write the book as a rating physician. We have to interpret it and apply it. Once, if it's in the book, say the person gets it, the person gets whatever is in the book. We can't rewrite it. I can't reinterpret how the book is supposed to be, and if it's fair, it's not fair. I don't have a whole lot of emotion when it comes to the book. I see the patient as I find them, and I make that range of motion testing and rating, and I just give it. And sometimes you just give it and you move on. And I've come to realize it's a full contact sport. You can't be afraid to see your own blood in this game. So because somehow every report there's going to be someone who likes it and someone who doesn't. And some days they're high, some days they're low. Someone walks out upset. So.
This one's 8 pages long. The other one, I'm having trouble with my Microsoft. It has 16 pages, and it just talks about an injured worker who comes in with a lumbar injury, and you apply the range of motion versus the DRE.
Okay, well, real quick, Doc, come on.
Because there is 8 more pages. I just
Yeah,
don't know
just,
it's not.
you'll be my patient. So, hi, how are you? It's nice to meet you. So, you see that? I'll sign that the D3 or the C4 form, sir.
Okay.
You're on the clock. So, is this your first injury? I have you in your low back, or?
I've had a few injuries over the years back playing sports.
Okay, so did you ever get hurt at work? When you say hurt your back, did you have surgery? And any problems with sprained strains?
My sprained strains.
Okay, so you recovered. You were working full duty?
Yes.
Okay, all right, so you never had a real injury in the low back? No surgeries, you've recovered from everything?
Correct.
Okay, so you get to work, and you were in Reno, and it was snowing, and there was ice, and what happened?
While I was out, doing my normal busking, doing my pirouettes in the street, and as I was shoveling my show, my feet slipped out, and I came back and I landed really hard on my butt.
Okay, and I see here in your records, you had, and then we'll kind of do this twice, you had no surgery and no fractures, correct? Oh, sorry.
Yeah, no surgeries, but I didn't have any fractures, but I do have a L5 spondylolisthesis, a fracture there also. So I think it was caused by the fall, but the doctor said no.
Oh, look at that. He's making a slight level more complexity. Okay, so you mean so did you get any injections for this?
I did get injections, yes,
For this injury or prior?
for this new injury.
Okay, all right. So no surgery was done to correct anything, and they suggested that this could have been before and you were living with it and you just didn't know it, or it could have been injured on this slip and fall, correct?
Yeah, correct. It wasn't hurting before, but now it's hurting ever since. And the injections, they didn't work at all, as we see in the records. They helped for a short term in the records, but then they didn't work at all. And they gave me 2 separate levels of injections. They did the lowest one first, the base, and that gave me some relief. Then they ended up going another level above, and it may have given me a little relief for a short term.
Okay. So, now we know this is his first injury. He said sprained strains, of which we all have. He was in high school, he played football or whichever, and he injured his back. We don't include that unless there was a true injury. Okay, so we're moving right along. Slipped and fell, first injury to the low back. They suggested that he has a spondylolisthesis, which is these two little bones called pars defect, and they broke, and that's where it could start a slippage of the spine, whether it be L3, L4, L5, on the S1, on the sacrum. And so now, here we are. Do you have numbness going down your legs, or has that gone away?
It comes and goes in my legs, and like most of our patients in our office, it's very challenging for us because most patients say it's numb everywhere. That's where Dr. Michoud comes into play. I get this blanket picture, oh, everything below my knee is numb and tingling. So today it's not, it was there in the past, but today it's not there.
Okay. So did you get any, did you get a nerve conduction study? A lot of people go, what's that?
No, I did not.
Okay, so no, they didn't do any electrical shooting electricity down your leg?
No.
No, okay. So we have no objective findings with regards to, we have a injured worker says they have the signs and symptoms. Okay, so you take that into account. At that point, we start doing some range of motion. Does range of motion come into play for a DRE category with first injury? We still have to do it. You can't remove the doctor from the exam. So to be comprehensive, would you agree to do range of motion?
Of course.
Okay, so then you'd also do straight leg test, which patient would lay on the table, you raise the leg, you measure the range of motion of the hip angle, correct?
Of the leg raise. Yeah, leg raise actually.
Correct.
Which is hip flexion, leg raise.
Correct. So then we'd establish, is there any nerve problem going down the tension of the sciatic nerve to see if there's any signs and symptoms. In this case, would you agree this would be a DRE method?
Well, except for the fact I threw in there that they did multi-level
Injections.
transfemoral injections. So,
But that doesn't constitute automatically range of motion.
well, it helps add to the idea of multi-level involvement. Because the surgeon wanted to do a fusion L4 or 5 with me, and I didn't want surgery.
Oh, but you didn't throw that in until right now.
You didn't ask.
No. Okay, okay, so we went from a DRE category, now the surgeon wants to do 2-level fusion.
And this is where we've had these real cases. That's why I'm trying to make it difficult. And just because I had an L5S1 spondylolisthesis, maybe a disc herniation there, and questionable protrusion L4-5, really no neurologic issues. And we see this often. I'm trying to think my patient, when he comes in, is this a DRE or is this a range of motion? Well, did he have a series of injections? And often say they had fantastic relief for like several hours or a day or two.
Right.
At least I know at one level they probably found the source of pain. Same as maybe a hip injection of a steroid gave great relief. Well, they confirmed it's coming from the hip joint versus something else. So this is, I know it should be difficult for him, but just we see this in our office, we're like, these are the hard cases. Is it truly L4-5, L5S1, which would constitute multi-level? Surgeon, of course, want to do the whole enchilada, get the big job done, do it once and be in and out of there. Rather have them come back in 10 years, reopen the case, reopen the claim, do L4-5 on top of that. So that's why we have a really hard time with these, because I don't have a bulging L4-5, I have a protrusion of 5 millimeters or 3 millimeters. The question comes down to is this clinically significant on this patient? And that's where I was trying to make it difficult for Bradley here, because we have these in our office, and these are the hardest cases.
And he's very knowledgeable about the book, so I see where he was moving the yellow brick road, and it was taking me down a road to the end. He's right, this is not easy, but there are 2 categories which we work within those categories.
Correct.
Yeah, so that being said, initially, would that have been a DRE category?
It easily, one injury, not a recurrent injury, not a recurrent radiculopathy, not a multi-level radiculopathy, not a multiple fracture. So the multiple concept is not there, which makes you think DRE.
Correct. Now, he changed it, said, well, the surgeon wants to do a 2-level fusion because of the benefit he got from the injections, and there are some signs and symptoms, and we would have to dig into the records to see what do the MRIs show? What does the EMG shows? What are the opinions of the treating physicians, which can move the needle into range of motion method? Correct?
Correct.
Okay. So
Which one's higher, range of motion or DRE?
sometimes the DRE category can be more, but because you can have a very successful 2-level fusion of the cervical spine, which only reduces your range of motion by 20%, maybe 30%, because the majority of the range of motion is in the first and second joints of the neck. So you can actually lose in range of motion. However, there's range of motion involved. So if they don't give full effort or they can't give full effort, you can have more. So, and sometimes after you do surgery on 2 levels, they had radiculopathy, now they don't. So now there's no nerve pain. So the 3 bites of the apple, diagnosis, range of motion, and a nerve, the claimant goes, well, my leg doesn't hurt. Surgery surgery was a success. I don't have nerve pain. And all of a sudden, they get 0 for nerve, which they kind of got that in the DRE category. So it depends on the claimant when you see them during the examination. Fair?
Correct.
Yeah, so, so it can be higher. Typically, they are higher in range of motion, but it's because it's been a second injury to the same body part, and they're doing multiple levels. So it can be higher, not necessarily. Because if the first surgery went foul on a first-time injury and they did a fusion and it didn't work and they have all these problems, but it's only one level, you could be in a DRE category 5 getting, you know, well, upwards of close to 30% total. So it just depends on the injury itself and the claimant.
And on the concept of multi-level, I had a few colleagues over the years that call me and they ask me, well, they had an L5S1 fusion, is that multiple levels? It's multiple vertebra, that's one level, it's motor unit. L5S1 disc is one motor unit as considered. Think about counting discs, not vertebra, when it comes to multiple level.
Even though there's 2 bones.
There's 2 bones, 1 disc, that's one level, that's 1 disc level. So multi-level applies if you go to L4, 5S1 because you've got 2 discs involved there. That makes sense?
Can we take a break?
Yeah,
Is
take a
this
break.
a good time?
It's a great time. We'll go to Ann's next.
Okay, great. We'll take a break. We'll be back in 10 minutes.
I was like,
Those are hard ones. I'm sure, like, gosh, why are they doing this? Those are hard ones.
of course.
Let's do
It's great.
Okay, we're gonna start, because we got lots to hit this next hour.
Good stuff, yeah. Right here. This is just from our earlier training. Do you know, of all the PowerPoints, is there one that is more appropriate that would put
Yeah,
a case
it
study
requires
in there
you.
for it to talk about an IME?
I'm here.
Like the
So
one
now
you
we're
did
gonna
at
do hand.
CSI, which one was that?
And hopefully we're gonna get through that one
If you tell me, 'cause I
quickly.
have 'em.
Yeah, I'll make it quick.
And maybe we can do
Yeah.
another,
Email it
just,
to me, I
you
can-
know, highlight it and do a case study. That would be fabulous.
Okay. Well, I could go over one. That's pretty easy.
They're gonna do hand, Hogan's gonna help them too.
Yeah, I
And
think
then
Dr.
she's
Hogan
gonna-
is an excellent patient.
And then Jenny's gonna talk about a PPD.
Yeah, he
I like
changed,
the way he withholds
he
information.
changes the game
And you
constantly.
talk about one side PPD, like a case study, just talk
There you
about
go.
it.
You ready to go?
Yeah, do you want me to send you one? Can
Yes,
you
yes, yes,
request it?
yes.
So,
Do we need to do that?
we're going to talk about hand. Okay, the hand is going to be incorporated to the upper extremity. So what does that mean? Well, the leg bone's connected to the hip bone. That's the same idea. So the hand is the most valuable part of your arm. Okay, each finger has every joint has a value in this book. And the book does, I think, a pretty adequate job at addressing upper extremity. It's a chapter that's easily confused when it comes to the fingers, and I'll try to simplify it as quickly and as easily as I can. So we'll start off at amputation levels. What is an amputation? Obviously, if something's cut off, there's a value. Correctly, karate chop, it's gone. So to explain the value of the arm and how the hand's value is the whole arm at the shoulder. If you amputate it at the shoulder, the whole arm is worth 60% whole person impairment. How we start doing calculations, if you lost both shoulders, both arms at the shoulder, that'd be 120% impairment. You can't get to 120% impairment. So you would combine using the back of this book. There's a table, 2 pages of it, on page 604, that you combine. Now, what does combine mean? It means 1 + 1 is not 2. After about 12% whole person impairment, fractions start coming into play. So I'll use a quick example. 50 and 50 combined is not 100. It's 75. So in order to get to 100, I would assume we have to die. We have to be 100% impaired. So the shoulder at amputation level, right here, arm is gone. Some of my unfortunate, and God bless them, my military colleagues and EOD that have stepped on landmines and such, and with the Department of Defense, and they get their arms blown off, and this is real. So they get 60% whole person impairment at the shoulder. Well, what happens if it's not their whole shoulder, and it occurs at the elbow? So amputation level at the elbow. Well, that's 57%. So you mean to tell me that from here to here is only, what, 3%? So your shoulder is only worth 3%. Well, then how do I get a distal clavicle resection at 6% whole person impairment? I go back to, I didn't write the book. I only apply it. Okay. Now understand that the doctors who have written this book are very intelligent women and men who write this book. They're all MDs, DOs, and chiropractors. I'm sure there's nurse practitioners have been involved, physician's assistants, that all have input some way, somehow, over the years in these chapters. So it's not that the authors are stupid people, but you have to understand that we have various different professions. You have neurologists, pain management physicians, you have orthopedic surgeons that all get a piece of a chapter. And then they go home and they go, you have 6 months to get something done. Okay. And you have to look at what is their philosophy of their job, their profession. So neurologists are very heavily based off of objective findings and activities of daily living. And an orthopedic surgeon looks at the joints completely different than a neurologist would look at anything. So it's how they're written. So that's where some of the confusion comes in, and that's why the first and second chapters are so important. So now at the, so we got 57 at the elbow. Well, what happens at the wrist? If you amputate your upper extremity at the wrist, that is 54% whole person impairment. So from the wrist up to the shoulder, it's 54 to 60% whole person impairment. So if you look at this, there's very little value if you look at amputation level for anything north of or proximal to the hand. The hand is the most valuable item, and each finger has a certain value. And then I'll go through the structure of the values. Your thumb is the most important and the most expensive part of your hand. Then we have index finger, and it continues to go down. You get less of a value as you get to the pinky, or the little finger. So we have all the fingers, and why are the thumb and index finger the most important? Well, this is the part of our hand that we utilize to do most of our work. We pick things up. You know, the keys, there's a tactile sensibility. Then as you go down, the value diminishes. So if you look, we don't have the book, but on this chapter is chapter 16. So the thumb is the most important, the index finger is the next, and then you have your middle, ring, and little fingers. That total is 54% whole person impairment. Then we have to look at the finger by itself and how the values go. We have an upper extremity value. Oh, well, let me beat back up. We have the whole person value. Then we break it down to an extremity, whether it be upper extremity, which are our arms, or lower extremities. Then each extremity, we'll talk about the hand or the upper extremity, it goes from an upper extremity value to a specific value of shoulder, elbow, or finger value. And these values, such as the hand, are in finger values, which has to be converted to upper extremity, which then has to be converted to whole person impairment. So this is, well, I say simple, if you follow what has been offered to us, which is not on the board, but it is a chart, is a tablet to show how you rate. And it's pretty simple. It's a nice, clean outline of how a rater should do it. The difference is where some raters get confused, I suppose. The thumb is all to be added. And I go, what does that mean? We have several joints in our fingers. With the hand, the thumb has such a high value because you add each joint up. In the other fingers, you combine the joints. When you add 1 plus 1 equals 2. When you start combining the other joints, 1 plus 1 does no longer equals 2. It can, because they're very small numbers, and it's almost a moot point. But there's a different way of evaluating the hand. So the thumb has to be evaluated by adding all the joints, and then you combine things. The fingers are all based off of combining the joints itself. Then we have to look at nerve in these fingers. We have there's two sides of a nerve, to make it simplistic. We have an ulnar and radial side. And what does that mean? It means every finger is cut in half. Just cut each finger in half, and they give a value. And they give a value of these fingers based off of which finger we're dealing with. And to explain it is, I go back to these two fingers are the most important because they hold the highest value because they have a lot of function. It gives us the ability as humans to utilize our fingers because we have all 5. Well, we have the fingers are cut in half. I'm going to make this easy so I can use my hands. Sorry, folks. Okay, so the fingers are cut in half. We we have an ulnar side and a radial side of a finger, and that's our touch and sensory. On this side, the closest to the body, the most important two fingers are, well, that's actually, it's not wrong. These two fingers are very important. They're cut in half. We have an ulnar and radial. Ulnar is this bone, radial is this side. What makes it important is sensory, is how you feel and how you touch. So in these two fingers, and these two fingers alone, the highest value of the loss of sensory is the inner side of your thumb and the inner side of your index finger. And this is because that's where we grab things and feel. So if something's hot and you lose that sensory value, you could get hurt. On the outside of your thumb, on this side, there's very little value because rarely do we walk around touching things with our outer thumb because we use touch from the inner. So on this side, you get more value for any nerve loss. On the outer side, you don't get much. Now on the index finger, it's the same thing. It's a lesser value on this side because no one walks around and touches and goes, hey, how are you? No, that just doesn't happen. So they give it lesser value. Now with the other fingers, these last three fingers, they are cut in half. On these fingers here, they give more value to the outer side of the finger because when we put our hands down, we're putting our hands down on the outer parts of our fingers. So we have more sensitivity and usage and function of our hands on the outer. So in these fingers, you get more value on that side of the finger and less on this side. That is all combined when you start talking about joints, fingers, and nerves, you start combining. So that's where the confusion when rating doctors start doing fingers and hands is understanding how the book is written to understand that the hand is very valuable. The nerves, the fingers are cut in half based off of looking where the nerves are. And when you look at the nerve, how badly is the nerve injured depending on the length of the finger? Is it the whole finger you can't feel, or is it only partial length of the finger? And at what level? How would you even calculate that? That's calculated using an amputation measurement. So the length of the finger, even if it's there, you'll use an amputation chart and measure where is this nerve located and where is the either loss of sensitivity or what side of the finger is that loss of sensitivity. So the rating physician has to look at where the injury is, what finger, and just follow the table. The table is very nicely done out of all the tables in the book of how to calculate. It's done very well, and it's very easy to read, but there's a lot of mistakes made with hands. Question?
What about if it's your dominant hand? Does that matter?
It does not matter with regards to hand measurements. The only time left and right comes into account is from neurological table in chapter 13, central nervous system, and it could come into things like CRPS of the upper extremity, where you're having your dominant side, and the what you use with regards to daily activity. Sound about right?
Yes.
Yes. Okay.
One more thing.
Yeah, go ahead, please.
So I had a case, a colleague called me Monday about, he was advised to recommend the hand. And I said, well, what was the problem? Because your topic is hand. Well, they had a hand injury. I said, what was the problem? What was the diagnosis? Well, they had carpal tunnel syndrome. So this doctor went through and rated every finger in the hand, range of motion and sensation, which is not appropriate. So often, make sure the rater is rating what was clinically significant, which was the carpal tunnel syndrome. And because carpal tunnel syndrome is a neuropathy of the median nerve, you need to rate the median nerve neuropathy. So we're checking for motor strength function and sensory function impairment. And there's a few small cases where, because it is a nerve, you really don't typically rate range of motion with that.
Correct.
There is an exception surgery, orthopedic surgeon. So those cases, we're gonna rate range of motion and the intrinsic hand function of the
But do
strength of
you,
the
at that
median nerve.
point, not to cut you off on that, you're absolutely right. And what he's talking about is as adjusters and how you do the D35 and everything else, this broad, rate the left hand. Well, what's the diagnosis? Where's the injury? Perhaps it's not the left hand, it's a nerve up here that has affected the hand. So the joints are perfectly good joints, but there's a nerve problem that's affecting motor and sensory. So a lot of times, like CRPS, you can't do range of motion. That's not, the injury is not the joint, it's a nerve problem. So it all depends on the diagnosis and how a rater interprets and actually utilizes the book correctly for an evaluation. Is that?
Definitely, yes. And then maybe like where Cripps has that exception, you can do range of motion and the neuropathy. But we do see a few of those major traumatic injuries, typically it's wrist, where some doctors believe you can only rate nerve function there, but we realize that you're checking the wrist too because they had screws in place.
Correct. Yes.
So those are not extremely common, but they do occur.
Yes.
And
But
often,
would you do every finger in the hand?
no, I
Correct.
wouldn't even address that.
Correct.
I wouldn't waste my time.
But you've seen it, because I've
Yes,
seen it
done it.
numerous times that it's like, wow, this rater.
I'm hoping I'm too lazy and too smart to do that. And
And I'll say, hands to start doing fingers take a long time. It's not a 15-minute in out. It's impossible to do comparatively because we're doing left and right. To do it accurately, hands take a long time. I'll take a low back any time of the week than a hand because it's a lot of work. And then when you do it, the calculations have to be accurate because very quickly between combination, adding, then converting from finger to upper extremities, converting that to whole person impairment. Not to mention if you're apportioning, and that's a terrible word because we're not apportioning, we're comparing, contrasting the contralateral joint using it as a baseline. So arguably maybe it's a backdoor apportionment is a term, but as a rating physician, all we want is to get some accuracy and have a plumb line, a baseline to say what was normal and what was not. I mean, if a 21-year-old can't move a finger, but on this finger he's full range, yeah, that's what you expect. It's a very young person, very energetic and has their life. But we get a 90-year-old who, hurt my finger because they're still doing, housekeeping or a belt in construction. They're a mechanic and stuck in a pulley belt and it injured their finger. The range of motion of a 90-year-old compared to a 21-year-old is quite different. And that's why the book allows a rater to have the integrity to compare and contrast contralateral joints. Fair?
Yes.
Got it. Yes.
Dr. President, Dr. Hogan, can you guys talk about just real quick, because then we're gonna move over to the site IME and give you guys a break. If you like, say, have an amputated thumb and how you get it from upper extremity to a whole person. That's where I think.
Well, okay, sure, we're talking about amputations.
Just one specifically.
Okay, amputation is very simple. It's a measurement. Okay, where is the amputation? At what level of the finger, of the extremity? So a value, there's a table, it's a simple table that if something is cut off, you just go to a picture of whether it be a thumb or a finger, and it shows you a measurement. And you take that measurement, you go on the x-axis, on the y-axis, and you just come across, and you look at a percentage. The finger is given in a finger value, whether it be it's 50% of the finger. Okay, that's at that level of amputation is 50. That gets converted to hand, which gets converted to upper extremity, and then it gets converted to whole person impairment. So it's it's a simple table. Agreed? Yeah. Amputation is very easy. And here's one thing, and I'm going off on a tangent with regards to fingers. I have seen, and why do I ask? Because, well, we're all human. So I see these after an injury, and they get severe, whether crushing injuries, amputations and such. And some people, because they don't want to lose their finger, no one wants to lose something that you were born with, and they say, no, keep the finger. I want to keep it, just do surgery. And they're left with a stub, essentially a useless dead finger that doesn't work. And then they say, I would have been better off if I just amputated it. But at that moment, we're still human. No one wants to get it cut off. That's part of your identity. It's what makes us human. It's a loss. You cut something off mentally, you're hurt. And that's where values come in. I literally, more people with finger injuries, crushing injuries and what have you, that they've lost nerve sensation and function. It's just a dead stick. They say I should have had it cut off because I can't do my daily activities. I stick my hand in my pocket, the finger gets caught. I'm working, I have to duct tape it together because I'm afraid to get it re-crushed or re-injured. Be cautious. When you're dealing with these people, probably what they should have done is just amputated it. But it's a big leap for any of us to do it. And then, like in the military, they get legs blown off. Then you have a phantom leg. You're feeling that it's still there. They get up and walk, and they fall. It's a part of us because we didn't know. We always keep feeling it. But their function, if you add activities of daily living, of which we can't in upper extremity, we can only apply ADLs in the state to the spine. If you look at that, that's where emotions and money and all this stuff gets all muddy. But fingers, I'd say majority of the time they should be amputated and not repaired. It will save thousands of dollars, and I've seen incredible results that if they amputate the metacarpal bones and they get rid of these two, and all of a sudden, but they have function. So never rule out, say, oh no. Sometimes I hate to say it, sometimes it's cheaper just to amputate it, but their daily activities, their lives are actually enhanced as opposed to, but I've seen everything, burns, fingers dying, from necrosis, right? Necrosis and all these things. So fingers are real. I mean, we need them. And when they're gone, there's an emotional component, which this could be a great way to turn into the emotion. You like how I did that? So I passed the torch.
So I downloaded at the last minute, the worksheet.
Thank you, everyone, for your time. Appreciate it.
Nevada, we do our own thing here with the site. I don't know why, because I do ratings in other states, but we have our own system.
Do you want to introduce yourself just real
Sure.
quick for those online and in person?
Sure, I'm Dr. Jamie Lee Saishon. I am board certified in psychiatry, neurology, and brain injury medicine, and I'm also certified by the IAIME and the ABIME, and I have a clinical trauma specialty certificate in PTSD, and I do treatments as well as evaluations, neuropsych testing, everything for workers' comp.
And you're bilingual?
I also speak Spanish and ASL, but nobody ever asks for the ASL. And I work at Encompass, where I'm actually the program director for brain injury and psych for Valley View and Desert Canyon.
Do you take patients, or you just do IMEs and PPDs?
No, we actually do active treatment for
Oh, you do?
EMDR. We just do everything. We do the medication management and the therapy together.
Okay.
Yeah.
Okay, sorry, thanks.
So
Wow, I'm getting my right. Super, yeah.
we started doing treatments because nobody else was doing it the way that we wanted to do it. So we try to be a one-stop shop. I have an NP who helps me. We're both certified in EMDR. That's the therapy we like to use. Which brings me to PPD, because I have seen a couple PPDs, and MMI for psych is a really difficult thing, right? Because normally in psych, and a lot of psychiatrists, they want to try this or try that or try something else. For the AMA guides, though, it can be a chronic condition. It just means that they don't expect to change within the next 6 months. And the problem is some of these patients become resistant to treatment. Maybe they try a treatment that doesn't really work for them. They start to get frustrated, they go a lot, they don't feel any better. Are they at MMI? Yes. Does it mean that if they went out and got their own treatment or tried something else, they might benefit? They totally might. But for the purposes of workers' comp, they can be considered stable and rateable. In some states, they have the choice to decline treatment. So then if they decline treatment, I can rate them. This is online. This is the D9C worksheet, which is, you're supposed to complete this at the end of each PPD. So it goes through the percentages and all that later, but let's start with the worksheet. So at the top, it has DSM-4 diagnoses. I always cross this out and put DSM-5 because we don't really use the DSM-4 anymore. I think they're gonna revise that this year. When it talks about the levels of impairment, again, like Dr. Raz mentioned, I think the areas of daily living, the ADLs, that comes from a lot from neurology because that's usually a basic assessment. With psych, the only areas that are really important are the travel, because a lot of these patients have issues with traveling, and then the sexual function and the sleep. So everybody says they can't sleep, so what I do with that is I usually go back and look at their records, see if they have any sleep studies, any issues with sleep apnea. For the sexual function, I wanted to make it a little more objective, so you can actually go online. There's an International Erectile Dysfunctions Questionnaire, an IED 6 or an IED 11, and there's also one for females. I tend to use that. It is a self-report questionnaire, but at least it's something that I can use as a guide to have a sort of gauge to determine how severe it is. Second part, looking at social functioning. I would say that this is the hardest one because a lot of times we see police officers. I even have an example of police officers. I always tend to look at managing conflicts with others, negotiate compromise. Did they get written up at work? Do they have any issues with that? Did they have any issues with their bosses, with their employment? The recreational activities, you can ask them about interpersonal relationships. Sometimes they bring their significant other with them. So I always welcome collateral information. I don't think that it changes my opinion. I just think it's useful. For concentration, persistence, and pace, I test them with the PPDs. I give them either an online IQ test or some sort of personality test, because if they're able to complete it, then I know that usually they shouldn't have any issues with concentration, persistence, and pace. One of the things that we treat a lot in PTSD is anxiety-related memory impairments, which often show up as other disorders or other claims, but it is well documented that in PTSD, patients have trouble with short-term memory, they have trouble with attention, concentration, things like that. Probably the biggest one and the most important one for rating is deterioration or decompensation in complex or work-like settings. Did they actually go back to work? A lot of these people do not go back to work. And then the question is, are they able to adapt to the job performance requirements? Is that the reason why they didn't go back to work? Or did they not go back to work for other reasons? In our own practice, we make them sign a statement that says they will go back to work during active treatment, because if we don't treat them when they're returning to the trigger, then we don't know if their symptoms have resolved. Some people do not want to sign this, and so they do not seek treatment with us. I always think of, is this also PTSD related work problem, reason for them not going to work? Did it just highlight underlying like interpersonal conflicts and stuff that they were having already, and then now they're using this kind of as an excuse? That's one of the reasons during the consult that we try to do some personality testing to determine like what we're getting ourselves into. But we do have people as well that were terminated from employment, so there was no job for them to go back to. It doesn't mean then that they should be rated on that, because they are able to go back to their job, they just do not have a job left. you're supposed to average the highest two areas of functioning. I never add or subtract the 0.5. I think I did once because I had documentation that a patient was over-reporting, but I try to be as objective as possible. And then from there, calculate the whole person impairment. This is a guide for gauging the minimal categories of impairment. This is I think what always gets people, because I think if you don't see psych patients, you automatically think that every symptom might be resulting in a lot of impairment, right? But PTSD patients are not the type of psychiatric patients that are usually hospitalized. They are not the type of psychiatric patients that are incapable of holding jobs. They are not the type of psychiatric patients that are incapable of having a normal life. Even in chronic PTSD, the expected treatment course is that they would have symptom reduction to the point where you expect 1 to 2 exacerbations per year, maybe once or twice a year around an anniversary or a major trigger, that they have symptoms for 3 to 5 days. For example, July 4th was really bad for us. We're really busy because of the fireworks. What happens? We have a lot of the cops. They have, bad weekend. But they've already been through treatment, so we just kind of do an accelerated thing. We can talk to them like, hey, they understand it's going to be about a bad week, all right? It's not the persistence of symptoms forever where it's causing all this severe problems. The only time I've considered, I think, moderate category of impairment is with respect to males with PTSD, erectile dysfunction, which can be related to both psychiatric medications and the event itself. If they're on chronic medications for erectile dysfunction, I think that that is a moderate category because they require medications for that. I've never marked anybody category 4 or 5 or 6. I would think that that would be related to somebody who was probably institutionalized. It's really hard for me to translate this, so I thought I would just show you guys some examples.
You have 2, can you see them both?
Yeah.
They should be easy to grab.
Yeah. Well, any questions first? Any questions? No? I feel like this form is not as specific as I would like it to be, so I've tried to make it more specific, and I'm doing a training. I use things that I like because it provides me with some objective data. For example, if I give somebody an IQ test and they fail it, I don't consider that person a reliable reporter, right? So I would then go back through their records and I look for, okay, what was their initial PCL or their initial testing when they saw somebody for treatment? Okay, what is their testing when they see me today? Is it higher when they see me today? Are they trying to report extra for effect? Is it lower? Is it the same? Those kind of things.
At the top, if you share the other document, it says to share the document.
There we go. Okay. So this is an example of a PPD. It was a person who was already rated. He had a multiple officer-involved shootings. He'd previously been rated at 2%.
Just for psych or everything?
For psych.
So you were a second PPD?
No, this was a second intervening incident. So after the first incident,
Oh,
after the 2%,
another.
yeah, he went back to work. He likes working. That was an issue for him. He told me when we started the rating, he didn't want a rating that would prevent him from working. So I was kind of concerned about that. He reported significant PTSD symptoms. He worked with SWAT.
SWAT?
Yeah, SWAT team.
And Christy, I sent you those to share, if they
Yeah.
want to share them, and they can kind of make more sense to them
They're redacted.
Yeah, they are. And I shared the D9C with you if they want to look at what she was talking about.
So the one important thing was he reported that he had intermittent dissociative episodes, dissociation. To me, when looking at PTSD, dissociation is a contraindication for certain types of trauma therapy. He had only experienced trauma-based cognitive behavioral therapy, which is not something that I usually do. But he had had that from another psychologist. And when you have dissociative symptoms, you're not a candidate for EMDR. It's risky to perform EMDR. So even though he had all these psychiatric symptoms and maybe he might benefit from other types of outpatient treatment, he was still at MMI because he had received the best evidence-based treatment based on his symptoms, right? Like I can't force him to get a treatment that might be risky to him with his symptoms. And so when I reviewed his outpatient, his PCL prior to treatment was 36. Is this guy being PCL5 is a scale that we use to determine the severity of post-traumatic stress disorder symptoms. It's a checklist of symptoms. It's max score of 80. People who are police officers tend to underreport, which was consistent with him today, given that his PCL when I gave it to him was higher. Like I said, I give them all personality testing. That way especially the police officers, I give them a different personality testing than everybody else because they know how to beat the regular one. So I tend to give them, they've all taken the MMPI before to get into the academy, so they know how to answer. So I give them a different kind, either a MIPS or an MBMD, because that's a test they haven't seen before. Sometimes the hard part of a PPD is thinking on your feet and knowing, okay, this might be a difficult or an easy patient. As mentioned, I give everybody a Ravens 2. It's an IQ test. If they score below a C9 of 2, I tend to be very concerned about their answers because it means that they either didn't pay attention to the test or didn't take enough time with the test or are purposely trying to answer poorly. Because most people would score above a C9 of 3 or higher. Even my brain injury patients, by the way, it's intact in brain injury. I did give him some self-report scales. As I said, his PCL today was 44. What does that suggest to me? When your PCL is above threshold and you've had treatment, it could be a couple things going on. Number one, you're over-reporting for effects, or it could be you have chronic PTSD and this appointment is exacerbating your PTSD, which happens a lot, right? If they know they have to talk about it, it's gonna make their symptoms transiently worse. We see it all the time. And the threshold for chronic PTSD for treatment is different than the threshold for somebody that has initial PTSD. If it's above 33, we start treatment if it's a first event. If it's higher than 45, we might do treatment if it's multiple events or chronic. So his was still below the range for where he would need treatment even if he has chronic PTSD. And those are guidelines that are published on the Department of Defense. So that's what we use. I give everybody a BTQ because I want to ask about every potential traumatic event that they had. It's a brief trauma questionnaire, provides a lot of useful information. And the cops, they mark everything, war zone, accidents, whatever. But at least then I know, okay, these are all the events in their history that I need to really ask about. Because he'd already been rated about a first officer involved shooting, right? So I need to make sure that if I rate him, I have to rate him based on the symptoms just due to this event. And that was important for this case because he mentioned how he lost his relationship, he lost his first marriage. He was already rated the 2% based on interpersonal difficulty at his first rating. So when I did his worksheet, I couldn't include that in his rating. I actually gave him a fairly high rating, one of the ratings, the 10% for this one. That tends to be high for me.
And that's based on
and the records and his worksheet. But most of it was from the interview with him, because I did find him to be reliable. And his major issues that he was having were not only sexual dysfunction and sleep, but ADLs. But he also had difficulty with, despite him saying that he was fine and wanted to go back to work, he had some issues with his boss. He had some issues with socializing with other cops and taking orders and direction. He was actually late to his appointment because he didn't delegate a task to an underling. Why? Because he feels like he can't trust people that he works with. So all those things are important. They kind of went into his rating. With certain patients, there's a presumption that they're telling you the truth, but they're not telling you all the truth, right? So it's your job to get out of them what you need to get out of them. And sometimes, instead of asking them direct questions like, how do you feel about your sleep? It's better to ask them, what's your day like? You know, what time do you get up? Are you tired in the morning? You know, what do you do? Tell me the last thing that really irritated you at work. You know, they love talking about that, right? So sometimes, because people always ask me, like, how do you structure the PPD interview? And I know people come to watch it sometimes, and I know maybe they're disappointed that it's not the same every time. But you have to read the patient, and if they're reluctant to or if they've already prepared a script and they plan what they're going to say about the event, you're not going to get any useful details from that. And the PPD is not really about the verification or not that they have PTSD, although it is important. The PPD is about how they're functioning now. How are their symptoms affecting their life now? If the presumption is they had this illness and they got treatment, okay, what is left over, right? What's the impairment left over? And when we do the treatment, we do put at the bottom the recommendations to other people that rate, because I am a rater, that, hey, look, this patient started to mention about halfway through treatment that they were getting a divorce. We had a patient halfway through treatment, and he's like, I'm getting a divorce. And I was like, oh my God. But he went back to his job. He had no issues with that. So in my recommendation to the rater, I said, look, I expect residual impairment because he completed treatment and his interpersonal issues with his divorce were not related to this incident, right? So I think that's why it's important during the rating to ask people, you know, what are they doing, what's going on? I had a patient recently that I did a PPD who, this is actually the one that I took a half a point off, because when she was talking about the incident, she was really fixated on her inability to perform ADLs due to her shoulder, that she couldn't move her shoulder, that she had continued problems with her shoulder. She had a rotator cuff injury which was successfully treated and with surgery. So the fact that she was still fixated on the shoulder and I'm not the same and I can't do things because of my shoulder told me that this patient has a tendency to be very psychosomatic as well as catastrophize and probably has adopted the sick role where she doesn't want to get better, right? Because when I asked her about her treatment, she felt psychologically she was no better. And I compared her scores today to her scores when she started, and they were actually worse. So to me, I felt this patient is significantly over-reporting, right? So I had to take that into account with her PPD rating. Again, I gave her a Ravens, and she scored a 1. So I was like, you know, I'm willing to give most patients the benefit of the doubt, but when they purposely sabotage their testing, then I have to go back to, okay, if I can't trust their subjective reports, what do I have that's objective, right?
What kind of job is she gonna go back to?
That's the thing. She was working as a student assistant, like a teaching assistant. And she reported that she never intended to stay at that position. Her goal was to work at that position until her son was better, her son had had some illnesses, and then she was gonna go back, get her psychology degree, and become a counselor at the school. Note to self, anybody that wants to get a psychology degree, there's gotta be something underlying. I'm just saying, like, they all wanna
Wait,
know.
what does that say about you, doctor? No.
Oh, me? Yes, for sure, I know. I own all my degrees. I do, I know. I tend to have latent anger, especially towards the residents when they mess up. But so that's the thing. When I looked at that and her rating, I was like, well, I can't really rate her on inability to return to work because she didn't really plan to return to work. And she kept talking about how she wasn't able to complete her coursework and that she thought it was because of, her symptoms. But she didn't renew her license. She felt that the anxiety and the stress was too much, and she felt that she wanted to just do something where she was gonna work from home and she couldn't have any other, like, goals. So again, that, if I was gonna rate her, I can rate her on her inability to set short and long-term goals, right? Because she doesn't have any realistic goals, so I can rate her on that. But adapt to job performance requirements and work on a schedule, those aren't areas that she mentioned she had an issue with. The issue was motivation to complete her goals, which that could be due to PTSD and depression, right? So for this is the only one I think that I've ever done that correction where I subtracted 0.25 for over-reporting. I think this was the only one. Usually I don't subtract.
What was her number at the end?
6%, which is still fairly high.
Is there a range, like, he talked about, Dr. Rushmore, about maybe between a 10 and a 13 or a 5 and a 20. Is there a 1 to a 20, or is a 1 to a 10, or it's just all over the map?
Oh, I gave her 5% and then, so combined, 5% plus the 13% previously is 17, not 18. This is what you learn with the book, the combined values chart.
Wait, what?
Yeah, so she had a shoulder injury, her shoulder was 13%. So I gave her 5% psychiatric impairment, so.
Oh, but it's 17
Yeah,
person.
yeah, by the combined values chart, which makes everybody crazy when they look at it, cause I always double check it, right? Yeah, so the 13 and the 5, yeah, 17. So I think that the ranges that I have tend to be lower than other people's because I have more people I have treated, if that makes sense. So in my mind, if you're gonna go back to this form and you're gonna say that, okay, so if you're gonna say somebody is these high numbers, like 6 to 7, or 16 to 18 is other category, or 26 to 32, right? Then you're saying that that person is so impaired that they're not really able, right? So if they have a chronic condition that's not likely to remit, which that could be PTSD, but it's disrupting pretty much most of their ADLs. And they need direction or supervision. So to me, that's a pretty severe level. That means somebody that can't even be left alone because you're worried about their symptoms. Most adults with PTSD, you wouldn't expect that to be their level of impairment. Whereas the category below, mild, yes, PTSD is not likely to remit. Yes, they might have ADL disruption. Yes, they might have some permanent impairment, but they're still capable of living alone without supervision, capable of working. So for me, the higher categories of psychiatric illness, there's very few psychiatric illnesses that we even apply those type of restrictions to. Even severe schizophrenia or schizoaffective disorder or bipolar disorder, the one restriction is driving. They have to get clearance letter from their doctors to drive, right? So for me, those levels of impairment, it's difficult to justify with just PTSD because even patients with psychotic disorders can still function fairly well. For me, category 5, requiring full-time supervision or hospitalization, that would be like a patient that I had in skilled nursing, like somebody who can't even take care of themselves. I have psychotic patients there. Sometimes they need direction to take their medications. They need things like that. And then even 26 to 50% serious difficulties in social or work activities, those would be patients like I have at Desert Regional who have severe autism. They require like mental health techs to direct them to go to work. They have to have a structured environment. They would live in like an ALF or an ICF. So that's the thing. Most of these patients are adults out there living in the world. So I don't really expect personally that the impairment will be those levels. I don't know though. Maybe that's because I am a psychiatrist and I tend to see a lot of range of patients. But I think that people forget that these PTSD patients, I always joke they're like the Diet Coke of patients. The Diet Coke of patients. Okay, because they're not the most difficult patients that you might encounter. Are they difficult to treat? Yes, because you have to always be aware of their other motivation and what's going on. But in terms of psychiatric illness, this is the illness, PTSD, this is the treatment, we know what to do, this is the treatment course. Even if they have residual symptoms from the treatment course, okay, we expect, like I said, 1 to 2 exacerbations per year, a couple days. If they don't get better at all with treatment, we have to start to think about other stuff going on, like personality disorders or secondary gain or things like that. We have a lot of patients that we've treated to complete remission. We do that, that's why we use EMDR. We find it to be very successful. But there are other treatment options. I know that everybody always talks about PTSD and they're always looking for other treatments. I mean, the board articles were talking about like psychedelics and things like that. It's a hard thing because they're talking about complex PTSD, which can be PTSD rooted in severe combat experience, childhood, things like that. So there is a continuum, like a spectrum of PTSD. And the good thing about workers' comp is usually you're talking about one kind of isolated incident. And then that's, again, why we use EMDR because we can focus on that incident. Yeah.
With the exception of TBI and personality disorder, some sort of relationship here depending on where the injury is, right?
Yeah, I mean, I even have patients with TBI and PTSD, and it's funny because if you explain to them that their TBI symptoms are not really TBI symptoms, like that their memory problems could be due to the PTSD, that's one of the only ways to get them into treatment. Because otherwise the cops, they're like, no, it's my TBI. I don't have the PTSD. It's like, dude, you do, okay? And so even explaining that to patients can get them into treatment. But I have a little spiel on the TBI too if you want to know about that, but that's okay.
Is it 5 minutes or more?
Well, the TBI, the natural course of TBI is actually that they're worse in the beginning and that they improve with time. So if they're getting worse with time, it's more likely a psychiatric illness because psychiatric illnesses tend to present with memory impairment as the psychiatric illness gets worse with time. So one of the measures that we use with some patients that have head injuries with PTSD is we start to give them a simple cognitive test each time they come, and then we actually show them, hey, look, when you started before treatment, you were like mild cognitive impairment, and now look, you're good. And the patients were really surprised by that. Because we have a couple patients with both.
What's your success rate
everybody that completes, our success rate is actually really good. We have, I think we only had one person that needed a rating out of most people. Some people finish early. We had a couple people finish before 15 sessions. I would say 75% of them complete without any residual symptoms. The other 25%, I kind of knew when I accepted them that something would go awry, and they either dropped treatment or decided that they didn't want to sign their return to work. So we had to discharge them. It's really hard when they drop treatment, especially when we know we can help them. And we still have an attrition rate. That's just the nature of trauma treatment. Most outpatient trauma treatment, the attrition rate is higher. It's like 30 to 50%. So I think having the workers' comp and having them like, they have to go makes it easier. But the ones that have always dropped treatment, it wasn't the nature of the trauma. It was the external factors, the family, that started talking to them about, or they ended up like leaving the job and then they wanted to sue the job and they didn't want to go back to the job at all. So the idea of having to sign a return to work was one of the reasons.
So my husband was the first firefighter to get a PTSD claim.
Oh,
And my husband was the first firefighter to get a PTSD claim. It was approved that they were accepting PTSD claims. So through treatment and through all that, he did get rating, and he's still, he's doing well, you know. A lot of his traumas that he suffers from, children drowning. Drowning is his big thing. Out of his 25-year career, he went on 14 drownings. So he suffers from that. And sometimes I wonder if he doesn't constantly keep himself busy, will he resort back to sitting and getting into those thoughts again? So that's why I asked you, like, what's your success rate? And like, would it ever just, you talk about an event happening, that it'll happen. Like during summer times is when he starts to feel that.
yeah, that would be a trigger for him.
Right.
We've had success with some patients with multiple chronic histories, with EMDR going after the worst event. And the literature success rate is 90%, but for us, we've had like 100% success. We had 2 guys, cops, retired, come to us, the same as your husband, already been rated. It wasn't about the rating, it was about really helping them getting better. And one of them had significant like hallucinations. The smell of certain things triggered him. And even with EMDR, he was able to kind of diminish that trigger and understand that trigger. So I do find it to be the most successful treatment. If I can't do EMDR, I will switch to do ACT or.
So just real quick, for those who don't know what EMDR is, can you explain it?
Oh yeah, it's eye movement desensitization reprocessing. So basically, I have you talk about the memory, and then I have an app on my phone because sometimes patients don't like me to touch them. But sometimes you go behind the patient and you just tell them relax, and then you have them talk about the event, and you can use bilateral tapping. I like to touch the patients because I feel like I can change my speed to in tune with their breathing, or I can go slower. Basically, the idea is you break up the memory. With the stimulation, it kind of decreases your arousal. It's a nervous system hack. It tricks your nervous system. The app that we have, it has like a little ball, or some patients like the lights or the sound. It all depends on, and we can set up speakers. The principle behind it is that we're humans and we think that we don't get programmed, but we get programmed like a computer. We get a virus, and the only way to get the virus out is to change the programming. And so EMDR, you have them talk about the event, but not in detail. You just have them, okay, imagine the worst part of the event. Tell me what you hear. Tell me what you feel. Tell me what you see. The sensory stuff. Because I I even have patients with TBI who say, I don't remember what happened. I guarantee you there's a memory in there somewhere. And it's very interesting because later they will get details that will come back. Because traumatic amnesia is not necessarily a component of TBI. It's more commonly a component of PTSD. And so I think the EMDR is beneficial because you're getting them to talk about the thing which triggered them, but you're not having them put it into words. You're just going after like their gut reaction. So they can't adjust it.
Doctor, we have a question.
Sure.
I had a question about after closure for maintenance treatment, similar to maybe a chronic pain condition. What are you seeing in terms of what maintenance is being requested once the claim is closed?
So for us, yeah, people always ask me that. So for us,
It's a hot topic.
I know. I have a hard time with that for two reasons. Because with EMDR, if they complete treatment and they're good, if they actually do need maintenance, I do have a patient, she lost a limb, it was very severe. Once a year around the anniversary, that's her trigger. And if she has symptoms, I recommend just like a short course, which would be 8 to 10 sessions. Normal course is 20 to 30. We tend to accelerate it at my office. We do the first 4 in the consult. It's history taking, introduction. I try to be snappy because the adjusters like that better. They're afraid to their life for like 30 seconds. But I can do that because I can do it, because I can get all the history and get all the stuff I need. So I did recommend for her like 8 to 10 sessions yearly around that exasperation of her symptoms, right? Instead of saying like, oh, I just need to see her once a month, because that does her a disservice too, right? Because then she's, what am I just gonna check in, she's gonna be fine, it's gonna be an easy patient, right? But it's not really what she needs. So in terms of trauma treatment, that's the recommendation. If they're on medications, which is rare with us, we rarely put patients on medications, but if we do, we try to take them off before the end of treatment. If they are still on medications, we recommend that they go to see their outpatient primary care or somebody else like that. If they continue to want them to see us, we see them every 3 to 4 months. I have a couple that I see every 3 to 4 months.
We're gonna have to wrap it up. I so appreciate you, Dr. Tyson. Thank you
That's okay.
very much for your information. Does anybody have any questions, anything going on online?
Nothing online?
Well then, another successful day
I
at
think that was
NUPC.
I've never heard of PPD just like I've never
Yeah,
heard
it's
of it.
fascinating. God bless she does it and we don't.
It's hard, right? When you have
It's hard.
different personalities, you have different intervening stuff going on, and it's up to you to figure out what came first, the chicken or the egg. That's a
So-
hard thing in somebody's mental state, and you're trying to figure it out and go through the weeds. That's probably gotta be a difficult situation.
I think it's hard. I think I'm gonna do the training, but I told everybody, I don't expect everybody to do my job. I recommend some people get a neuropsych eval before they do the PPD rating, and then
Do we have a neuropsych?
that's me.
She does it.
Oh.
I do it.
Okay, I was like, so you want them to have a neuropsych with you before we start the rating?
Yeah, because if they wanna do the rating and they wanna rate all the body parts and rate the psych with that, I have no problem with that. I can do an eval, tell them what I think is going on and give them recommendations, and then they can just rate all the body parts
No,
together.
she's not. She
So-
just, Sandy just said, can she be the treater and the rater? That's not what she's saying. She's saying, if we're a PPD.
Not a treater,
do the
just
neuropsych
neuropsych
testing.
eval.
No, I know, but
Yeah.
Sandy said, can she be the treater and the rater? No, she cannot.
Not a treater and rater, but
No, but
Psych
neuropsych
testing.
eval, so that when they go to the rating, they use that. She prefers not to do the rating. Even though she's a rating physician, the neuropsych eval is something needed for PPD, but it's not the PPD. It's just like.
But there's no one else to do psych.
Right, okay, I
No,
don't,
there's nobody else to do.
No,
Well,
neuropsych testing.
we're gonna have the training, and we're gonna get more people trained to do the psych
You can
PPDs.
do the neuropsych eval and the PPD if you are the PPD rater, but you prefer to do the neuropsych and have somebody else do the PPD.
Yeah, I usually do that, and we're training, and more people are gonna wanna do the PPDs, and the other people are gonna want the chiros to do them, because they're gonna do all the body parts, which like I said too, is sometimes better for these patients because they start to hate to have to go to this PPD and that PPD. I just recommend that they get a neuropsych eval, especially if it's a head injury, so that they know what they're getting into and that they at least have some recommendations. If I've been the treater, I do a comprehensive summary for them at the end with my recommendations. But I just feel like if we're gonna have more people doing these ratings, which I know we are, I don't expect them to be able to do my job. I just wanna give them all the information that they need to be able to do my job in addition to the rating. Kind of like my own little guide, because I do feel like some of this is very difficult.
It is, so you are gonna be working on the training for the chiropractors to be able to do psych.
Well, it's not just
down the line,
chiropractors,
right?
it's
Doctors
all
and
It's
physicians.
all
yeah.
physicians.
Well, the MDs already can, correct, or they have to have specific?
No, there's specific ones that were already trained
Okay, just a few.
prior to this
This change.
statutorial change.
Yeah.
But to add to her statement with the neuropsych, even in chapter 13, it's valuable when you have people say, well, I have a brain injury, I don't have, my memory is not as good as it was before. It's nice to have that kind of evaluation. Now, the book doesn't require it, so you still can utilize the book and the table, but it's a nice thing to have.
Yeah, I've had a couple requests from it. Like I said, it's just something that I think is valuable for everybody.
And there are neuropsychiatrists or psychologists that do these.
Yeah, but I'm better.
Oh, I know. You're best. I'm not saying, but.
I think we only
Yeah,
have
yeah.
one other.
There isn't any neuropsychs besides her that does it for work comp. The brain unit, the brain building has lots,
Right,
there's a couple there,
correct.
but it's not work comp.
Right.
After Mortallero left us, we haven't
Yeah.
had anybody since Dr.
Correct,
Sison returned.
correct. Mhm.
All right, well, thank you so very much.
Good job.
I so appreciate it.
Everybody online, you will get the DRE, so Dr. Resident's PowerPoint. You'll also get that D9 from Dr. Sison and the 2 case studies. I will send those out to everybody that was registered. So just
By
keep
far,
an eye out for
your-
that in the next couple of
Your
days.
colleagues
We're gonna go ahead and do raffles right now.
and Biblis.
We also ask that if you are a member and are expecting CEUs for this, that you make sure we have your license number. Because otherwise Trish has to hunt you down.